Welcome to Pediatric Simulation Cases, brought to you by TREC, Translating Emergency Knowledge for Kids, and EM Cases. I'm your host, Dr. Anton Hellman, and here's the case. Parents present to triage with a 6-month-old baby girl who has a history of lethargy, poor feeding, increased respiratory rate, and feeling warm. She's a previously healthy, breastfed baby who had a normal labor and vaginal delivery. Her immunizations are up to date. The triage nurse places the baby in the resuscitation room.
Okay, Carrie Lynn, can you hook up some monitors for me, baby? Just gonna have a little lesson here. So I guess mom is still at triage.
Mom's still triaging.
So I'm hearing a good fast heart rate, air entry bilaterally, and she's crying for us right now. I'm just gonna kind of check her cap refill here, and centrally as well.
I think it's about 4.
Yeah, it's a little delayed. So let's check the pulses as well. Okay, they're a little thready, but present. So I'm concerned, have we got monitors on yet?
Monitors on.
Okay. So I'm concerned just the baby's looking a little bit shocky. Heart rate is 166 and our SAT is actually low. So let's get the ambu bag going here.
I'm just going to quickly do a temperature.
Good. Okay.
So I really liked how they did a head-to-toe assessment. I especially liked how they put the monitors on quickly. I thought that was well done. Great to get a good set of vital signs right away. I like the fact that the physician mentioned the patient was shocky. I think using the word shock triggers people to appreciate how sick the baby is, and clearly this baby's in shock. Even if the child's not hypotensive, having a child that is tachycardic, has poor pulses, prolonged cap refill, that tells us that the child's in shock. Certainly the change in level of consciousness worries me. That tells me about perfusion to their brain. And so I think that the fact that he mentioned shock really gets his whole team ready for what needs to happen next. Last point before we get back is noticing the saturations are 91. I'd say any baby that you're worried about shock, even if their SATs are 95, it's great to apply oxygen because we know that increasing their SATs even by 5% is going to improve their oxygen deliveries.
Can we also do a glucose?
We'll do a bedside glucose.
Oh, that's going to be too big, so let's switch off.
Dr. Conley, the baby's temperature is 38.9.
Okay, so...
RBP is 74/44.
Okay, and she's 6 months, so she should be better than that, and she is looking a bit shocky.
What I'm concerned about when I see that video is that there's actually no oxygen being delivered. He's actually just holding the ambu bag, so it's just really important to remember that there's no free flow oxygen through an ambu bag. So you actually have to give oxygen either through an MIE or with a face mask.
So let's let's start an IV and let's do some blood work as well, okay? I think with that temperature, the safest thing would be to kind of do a septic workup here.
I'm just going to do a quick heel poke for the glucose.
Perfect. So our O2 SAT still is not coming up. I'm going to see if I can turn my flow up a little bit more.
How much do you think this baby weighs? I grabbed the Brazil tape.
Perfect, okay.
1, 2, 3.
What do you think
4.
about?
IV failed.
I better turn it around. I think about 7 kilos.
I see 6 for that length, so we'll work with 6 kilos.
Dr.
Okay.
Comby, my IV failed on my first attempt
Okay,
here.
can we try one more? If not, let's get the IO, the easy IO, please. Sorry, I know you did the glucose. Can you just repeat it back to me?
Yeah, it was 5.2.
Okay. Okay, so baby is a little more silent now. I'm not liking that very much. So oxygen level is still okay. I'm not going to give any positive pressure at the moment, but I may need to begin bagging this baby.
I couldn't get it.
Okay, let's go for an IO.
I really like the way that they use the Brazo tape, and remember to
Yeah.
use the Brazo tape to measure the child. Remembering that the Brazo tape can also give you medications and weight-based
Absolutely.
vitals as well.
One thing that we often forget, even here sometimes, I find our residents forget, is doing glucoses early. And they did it really early. And seeing that, especially in a small child, we know they can get hypoglycemic pretty quickly in sepsis. And so seeing that they checked that right away was great.
This is going to need a flush, Lauren.
Here,
So we've already got that set out.
And then I really like the fact that they just quickly went to an IO. I thought that was great. They had 2 attempts, things weren't going well. The child clearly is in distress and needing fluids, and so going right to the IO was a great thing.
Yeah, thanks.
I'm just watching the nurse bag the child, and the baby's crying, and she's bagging them. And I appreciate that, like you mentioned, Gina, because of their choice with the self-inflating bag, they have to bag to give O2. So certainly in this type of patient, what would be preferable, like you said, is an O2 mask, an MIE, and just hold some O2, because bagging a crying child, changing their intrathoracic pressure, it's not going to be great for them. So I do think that that's something that we could do differently next time.
Okay, and so we're going to want to give a fluid bolus now, okay guys? So
How much do you want us to give?
let's give 20 cc's per kilo. So
Okay.
she's 6 kilos, so 120 cc's. And let's make sure we give that within the next kind of 5 to 10 minutes. So bolus, okay?
We'll let you know when the first bolus is
Okay.
completed.
So I think that it's great that he said that he had to give the fluid bolus very quickly. It's very important that the fluid bolus is given over 5 to 10 minutes and not just run over the pump. He didn't really specify what type of fluid he was going to give, so
Exactly.
it's important to say that it is crystalloid that you want to give, that it's going to be normal saline most of the time.
And most children, actually, we can just give it push-pull. And so giving it, just saying to the nurse, draw it up and push it in, it'll even get in faster than 5 minutes, which this patient needs.
So again, noticeably baby is quite quiet at this point, but satting okay. So let's just recap, guys. So we've got a 6-month-old who's been lethargic, not feeding very well, is looking shocky, and basically was peripherally shut down. So I think we'll continue with our septic workup. We should start thinking about some antibiotics as well. So once we've drawn blood cultures and have a CBC, lights, VU, and creatinine, etc., let's give baby a dose of vancomycin and of ceftriaxone.
Sharing your mental model just means that you're telling the team what you're thinking, and it's about getting everyone on the same page. And I really liked how he did that. I think it's so important to recap every now and then in a recess, just to say, guys, this is where we are. It really frames your experience, and it makes things better for the patient.
So it's important to give antibiotics now. It's really important to give
Yeah.
antibiotics early.
Yeah.
I think it's great if you can get cultures before you give antibiotics, but this child doesn't actually have a line that you can get blood out of, so you really should not be delaying giving antibiotics to wait for cultures.
I agree. And if you certainly can't get anything out of the IO, you just push that antibiotics in the IO. I think that people worry about making sure they get Cef and Vanco takes a while to go over the pump. So even just giving that ceftriaxone right away is so important. So yeah, I'd like to see that ceftriaxone get given right now.
As the first bolus is starting to infuse, I'm going to attempt now to get another peripheral IV
Perfect.
to establish 2 sites.
So I am concerned the heart rate actually is a little worse than when we first started here. So let's get a second bolus ready to go.
Okay, the first bolus is in.
Perfect.
What's nice to see after you do a second bolus, and I'm not sure, or a first bolus, or I'm not sure if they're going to do this, is a full assessment again. And even though it sounds like a lot, it only takes about 10 seconds. And I think he's going through the vital signs a little bit, but it'd be nice to see a cap refill check, a pulse check, and also actually listening to the lungs and feeling the liver just to make sure you aren't missing something different. It's very unusual for children to have like myocarditis or cardiomyopathy, but it's good to check after each bolus and do a head-to-toe assessment.
I'm also concerned that really in terms of what the resources we have here for this baby and how she's looking, we're likely going to need to transfer her to a more definitive pediatric hospital. So let's finish up what we're doing here, but if we can maybe get in a third nurse or someone to help and make a phone call to
Okay.
critical.
Excellent.
Okay, so our blood pressure actually is a little bit lower now. We're now working on our second bolus.
All right, the second bolus is in.
Okay.
What antibiotics do you want?
So we're gonna go with vancomycin and ceftriaxone.
Okay.
If someone can drop a third bolus, and I'd also, I think if she's not responsive to the fluids, then we need to be thinking about pressors. The easiest thing's gonna be dopamine, right? It's pre-mixed. So again, I think let's make sure we have our third bolus, but let's get our dopamine ready as well.
Okay, so I'm successful with my AC, IV.
If someone has a moment, I'd just like to have someone auscultate baby's lungs just to see what's going on there. Make sure we're not kind of now pushing her into more of a failure picture with the fluids. Okay, so to recap again, baby now is requiring oxygen, positive pressure ventilation. We've got blood work cooking. We have an IO in, an IV as well. So we have 2 sites. We're on our third bolus of 20 cc's per kg. And we're now going to start getting our dopamine ready for this baby.
What do you want to start the dopamine at?
10 mics per kilo per minute.
So let's just stop there and talk about choice of inotropes. So we know that the current published guidelines for pediatrics suggests that dopamine would be the first inotrope to start if you have fluid-resistant shock. There is some recent evidence that maybe shows that epinephrine is superior to dopamine, which in some ways parallels the adult literature, which has suggested epinephrine as first choice for septic shock.
And without evidence to suggest that dopamine is just as good, I think we're left with choosing epinephrine as our first choice in cold septic shock from now on.
Having said that, I think it's still most important just to start something as early as possible. So once you have that child that you've determined has fluid-resistant shock, it's important to start an inotrope. And if dopamine is what you have easily available and when it's pre-prepared, then that's what you should start.
Certainly, and if the patient is not improving after you've escalated to 10 of dopamine, you're going to add epinephrine anyway at a dose of 0.05 mics per kilo per minute and escalate as you need to. Certainly, if the patient improves, we can start dropping down that dopamine, but I agree, I wouldn't want a patient's therapy to be delayed based on what's available and what's not available.
Yeah, and this is, of course, for the vast majority of pediatrics where they do present with cold shock.
Of course.
And for that sort of older adolescent that presents with more sort of a warm shock picture, then norepinephrine is your first choice.
Definitely, and that hasn't changed at all in the recent literature.
So is there anything that I'm forgetting here, folks? Any other things that you can think of that we need to be addressing for this baby? I guess mom, we should update and also explain our concerns and also explain that we probably are going to have to transfer baby.
Okay. Are we comfortable with the status of the airway?
So that's a great question. So I think that we should probably get some airway equipment. I mean, baby is still spontaneously breathing, but needing a little bit of additional help. Can someone actually auscultate for me? Do you want to take my stethoscope here?
I can raise.
Baby sounds good.
Do you
Clear
hear?
air. Baby has clear air entry bilaterally.
Okay.
Okay, so I'm starting the third bolus, and it will be a push-pull bolus of fluid. Are we thinking that we may need any blood at any time?
So no, but I think that our blood pressure continues to be poor. We've given 2 boluses. Is the dopamine running at this point?
I've started the dopamine at 10 mics.
Okay.
And I'm gonna just give the ceftriaxone dose push.
Carrie Lynn, when you're finished, I think we probably also should entertain giving this baby steroids.
Okay.
So we want to drop 2 milligrams per kilogram of hydrocortisone.
Perfect.
I think the second thing that we can talk about around this point is around steroids. Unfortunately, we don't really know what the right thing to do with steroids are. There's lots of studies that are ongoing. At this point, I think what a lot of us in critical care are comfortable with is that if a patient has known risk factors for adrenal insufficiency, then we would start steroids early. So patients that are on chronic steroids, patients that have something like known adrenal insufficiency, patients that have purpura fulminans, we would use steroids relatively quickly. I think in the other population where there's no known risk factors, most of us are considering them when we're adding a second inotrope. Is that your sense as well?
Yeah, so really the role of steroids is when you determine that they have catecholamine-resistant shock. So I'm not quite sure that this is that stage yet.
I agree.
Certainly if they didn't have response to a second inotrope, I'd be considering steroids.
Exactly.
So our heart rate has improved somewhat. It was up in the 190s, it's now in the 170s, but I'm concerned that our systolic BP is 61 and our diastolic is 33. So we've got a wide pulse pressure and we're getting close to, for our sepsis protocol, what we would be giving in terms of fluids.
I think one of the priorities now that's not happening is just more fluid. I mean, we're still seeing a patient that's quite hypotensive and shocky, and I think just consistently giving fluid in that push-pull method is important. We know that sometimes these kids can get up to 200 cc's per kilo in the first hour, and we've only done 60. So certainly if the child still has clear lungs, the liver size is not enlarged, and they're still being fluid responsive, meaning their heart rate's coming down and we are seeing some changes, I think we do need to continue to push fluid. So it'd be nice to see them give a bit more fluid than they're giving, actually a fair bit more fluid, until they're unable to see a response.
Yeah, or they, like you say, or they show signs that they're getting fluid overload.
Exactly.
What was our first bedside glucose?
It was 5.2. Do you want me to do another
Would you
one?
like that repeated?
Yes, please. So the other thing we can do is to actually titrate up our dopamine infusion if we're not achieving a good enough MAP.
Thank you, clerk. I have critical on the line here for you.
Hi there, this is Dr. Crombie.